One of the common sites of osteoarthritis, OA, is in the knee joint. People who suffer from OA in the knee joint experience stiffness in the knee pain, and are unable to perform some physical activities related to everyday life. This disruption in the ability to perform everyday activities is a strong cause of mortality and morbidity in people aged over 50. At the moment, treatments available include surgeries of the knee joint called arthroscopy, high tibial osteotomy, a knee arthroplasty, and interventions via pharmaceuticals are used to reduce the pain associated with OA and the inflammation. Treatments such as knee bracing and specified footwear are also available, but it is unclear how effective they are at alleviating the symptoms of OA. For PICO, the population was decided to be adults over 40 years of age who had osteoarthritis or any other knee stiffness. The intervention was the use of massage
For the Pedro scale, we made a table to assess each criteria. First criteria is eligibility criteria, which is satisfied. In the page 1702, methods, paragraph 2 mention about inclusion. The second criteria is random allocation, which is satisfied. As in the page 1704, methods, paragraph 3 has discussed subjects were randomly assigned to their test or control group using computer-generated random numbers. The third criteria is concealed allocation, which is not satisfied. In page 1703, methods, paragraph 2 has been cited. The study was explained by the study coordinator. So this means that the person who determined if a subject was eligible for inclusion in the trial was aware. The fourth criteria is baseline comparability, which is satisfied. In the page 1705, method analyze, paragraph 1 mentioned the key points. The fifth criteria is blind subjects, which is not satisfied. In page 1703, methods, paragraph 2 has been cited. The study was explained by the study coordinator, and the subjects were asked to complete a general health information form. The sixth criteria is blind therapist, which is not satisfied. In page 1703, methods, paragraph 2 mentioned about this. The seventh criteria is blind assessor, which is satisfied. Page 1074, methods, paragraph 8. The line that starts with the control group received a pair of high. The eighth criteria is adequate follow-up, which is satisfied. In page 1705, methods analyze, paragraph 1 discussed rates of non-participation and losses to follow-up were reported for both groups. The ninth criteria is intention to treat analysis, which is not satisfied. In page 1705, methods analyze, paragraph 1 discussed about this. The 10th criteria is between group comparison, which is satisfied. It has been discussed in page 1705, results, paragraph 1. The last criteria is estimates and variability, which is satisfied. As it mentioned in page 1705, results, paragraph 2, pain, paragraph 3, balance, and paragraph 4, ROM.
Biases. The most prominent risk of bias in this study is the risk of placebo or lack thereof. As a control group were given New Balance 756 WB model shoes, they would know that their shoes are different from the MBT shoes and therefore conclude that they may not get any results.
This could lead them to downplay or disregard any results that they have, due to them thinking that they are not expected to have any improvement in their condition. The experimental group is also at risk of this, due to knowing that they have an MBT shoe on. This could skew the results, leading them to record data that seems better than the control group, simply due to them knowing that they have an intervention on that is expected to work in their favour.
According to the results of the study, there does not seem to be any evidence within the results that strongly support the use of Maasai barefoot technology, MBT, compared with wearing regular shoes within the control group, especially from a statistically significant perspective. The subjects involved served to be a strong point in the study, in that out of the total 125 subjects between the MBT and control group, only one subject from each group dropped out prior to the initial follow-up, keeping the subject total high and consistent. There was no statistically significant difference between each group with regards to pain over the 12-week period when walking using the VAS visual analog scale score, as the p-value was only 0.28. The reduction in total pain was included within the results so as to differentiate from just walking pain, but unfortunately had poor strength to validate their results, reaching a 0.8 p-value. The MBT only performed higher in regards to reduction of pain between weeks 3 to 6 and 6 to 9 respectively. However, in the long run, they were almost classed on par. Balance was reported as having no significant difference between groups when asked to stand with their eyes closed, as it states that a p-value of 0.076 at 12 weeks was measured. Range of motion within the knee, ankle and subtalar joint were measured over the 12 weeks and as a whole presented no statistically significant results at the end of the 12-week period. Knee flexion achieved a p-value of 0.79 and knee extension of 0.14, respectively. Plantar flexion in the ankle scored a p-value of 0.6 and dorsiflexion a 0.32, leaving subtalar inversion 0.6 and subtalar eversion 0.93, respectively. Peak isokinetic strength was measured with no avail for strong evidence between plantar flexion, dorsiflexion, inversion or eversion, with p-value results of 0.28, 0.39, 0.86 and 0.47 respectively. When summarizing the main findings, it was clearly shown that the only differences between groups was between weeks 3 and 6, because it all started to blend to similar results afterwards, leading up towards the 12-week mark. In reference to balance, the MBT group, although showed no significant difference at the end of the 12-week mark, actually showed better balancing performance compared to the control group during the 12 weeks. The findings within the results sends a clear message that there really is not a lot of difference between the use of MBT shoes and regular good walking shoes for subjects suffering pain in the knees due to osteoarthritis. The research also highlights that more investigation is required, particularly over a term of 1 year is recommended to truly ascertain where the benefits are. It also mentions that any future research should concentrate on the functional changes that are responsible for the reduction of pain.
Potential risks of integrating MBT into clinical practice. There are a few risks involved with this study. There were risks of biases such as placebo due to the patients having visibility of their foot. There is also a risk of falls due to the instability of the MBT shoe and the increase in small muscle activity that is needed whilst wearing it. It should also be noted that both good walking shoes and MBT shoes are expensive, which could impact the patients financially, leading them to refuse treatment. They are also very cumbersome to wear and not very fashionable, which could decrease the appeal to wear them. Potential benefits of integrating MBT into clinical practice. This study also showed the potential benefits of MBT shoes. It was discovered that using either MBT shoes or a good pair of walking shoes helped to improve the balance and the pain of patients suffering with moderate knee osteoarthritis, more than other less well-constructed shoes. Even though this improvement was not statistically significant, it was an overall improvement in both pain and balance, which is the end goal for a medical practitioner. Due to the close nature of the results, it can be suggested that wearing MBT shoes over a good pair of walking shoes would have no ill effects on the patient. Clinical recommendations. It is recommended in practice that patients who are suffering from moderate knee osteoarthritis can benefit from either MBT shoes or a good pair of walking shoes. The cost, living environment, financial situations, and burdens from treatment should all be considered to determine which is right for the patient. However, these interventions should not be used in isolation or in place of other treatments, and should be used in conjunction with other methods of reducing the effects of osteoarthritis to ensure that the patient gets the best possible outcome.